Okay, try that again. There we go. Well, this is Alan Budens, and I want to welcome everyone to tonight's discussion of options for mandibular anesthesia. What I'm going to do this evening is present material for about 45 minutes, and then we'll spend the rest of the 60-minute allotment time we have talking, answering questions and talking about any other generalities that we might have. So let's go ahead and get into the program here. First off, in terms of thinking of mandibular anesthesia, can we use infiltration injections? Certainly simple, safe injections to do. And in general, our opinion has been that, well, it works fairly well, but, works better for the anterior area than it does for the posterior, somewhat unpredictable in the molar area. But there have been some research papers published in the last few years that have looked at the efficacy of different agents for using infiltration anesthesia. And what we see, looking at this paper here, this was Robertson and his group published in the Journal of the American Dental Association back in 2007. And I think this was a very well done study. What they did in this study is giving block injections only, giving infiltration injections only, no block anesthesia was given. And what they did was at different appointments they gave a single buccal infiltration, sometimes with 2% lidocaine with 1 to 100,000 epinephrine, at other times using 4% articaine with 1 to 100,000 epinephrine. Common commercial names for articaine would be Septicaine or Zorcaine. So what they found, and I think it's very interesting, is that in giving just a buccal infiltration using lidocaine, 45% of the time they got pulpal anesthesia when they gave that over the second molar. Now, I've got to be honest, that really is surprisingly high in my opinion, but that's what they got. Now, as they move forward to first molar, second bicuspid, first bicuspid, with lidocaine, they had 67%. Good, profound pulpal anesthesia. But look at the numbers here when they did the same thing with articaine. Using articaine over the second molar, 75% of the time they had pulpal anesthesia, and over the first bicuspid, 92% of the time they had pulpal anesthesia. Now, what else is interesting here is that they also got faster onset using articaine as an infiltration. Notice that the lidocaine, it varied between 6 and 11 minutes. The articaine injections were always less than 5 minutes, so clearly a faster onset. Something else to think about that I think you're all very familiar with is that when we give a buccal infiltration with articaine, we get the buccal soft tissue, we get pulpal tissue, but frequently we also get lingual soft tissue anesthesia, which means we wouldn't necessarily have to give a second lingual infiltration injection to have complete anesthesia and comfort for the patient. So this is a really nice advantage as well. Now, one more thing that I think about, particularly for the molar area, is that when you look at the anatomy back here, you look at the buccal plate area, we have a thick cortical plate out here and a fairly thick ledge of bone. Whereas when we look at the lingual side, we all know there's a thin lingual plate there that is somewhat susceptible to fracture if we're doing an extraction. So what many of us are doing now is we're using lingual infiltration in the molar area, simply putting the needle in parallel to the alveolar process down into the lingual vestibule, if you will, at the floor of the mouth, approximating the apex of the molar tooth there and depositing our anesthetic there. What I like to do is I use half a cartridge of articaine to give a lingual infiltration, and I do also use the other half of the cartridge to give a buccal infiltration for that same tooth there. And this works very nicely for getting a single tooth anesthetized to do a restorative procedure on a mandibular molar tooth. You can do this on bicuspids or anteriors as well. Although usually in the anteriors you don't need the lingual infiltration, the buccal will be plenty adequate for anesthesia. So this raises an interesting point that articaine seems to be better than lidocaine. Now here's a paper, again published in the Journal of the American Dental Association. This was in May of 2011. And what this group did is that they with very good criteria. They went through quite a number of studies and sorted out what the best quality studies were. And what they found from this meta-analysis of the 13 papers they ended up looking at was that the evidence was very strongly in support of articaine being superior for infiltration anesthesia versus the use of lidocaine. Very clearly, it works better. But I think it's equally important to note here that the evidence was weak for any significant difference between the use of lidocaine and articaine for block anesthesia. No real advantage has been found in any paper that I've seen comparing lidocaine to articaine for blocks. And here's another paper. This is from January 2013 out of the Journal of Endodontics. This was a study comparing articaine to lidocaine for blocks and infiltrations. This was on teeth that had irreversible pulpitis. So hot teeth, which we all know are very difficult teeth to get anesthetized. Articaine was 4 times more effective and gave greater duration than lidocaine as an infiltration for these irreversible pulpitis teeth. So again, there's been quite a few papers with very clear indication that articaine is superior for infiltrations. So for me, my basic anesthetic armamentarium, 2% lidocaine with 1 to 100,000 is still my workhorse, what I use for most block anesthesia. I use a little bit of mepivacaine, carbocaine plain for those very short duration procedures, or for the occasional patient where I really don't want to use any kind of vasoconstrictor. Articaine, and I prefer the 1 to 200,000 heparin just because it's a little safer in case I accidentally inject it into a blood vessel. This is what I use for infiltrations. This is my favorite anesthetic, certainly for infiltrations, and almost the only one I use for infiltrations. I do sometimes also find that the 4% solution does work better for hard to anesthetize patients. And what I'm thinking about there, patients with a history of drug abuse, whether it's past or current, patients that drink a lot of coffee, patients that are heavy smokers, or patients that take a lot of medications, whether they're prescription or over-the-counter medications. Lots of times we find those patients are very hard to get numb, very hard to keep numb. And you'll see this reported quite a few times. These are all anecdotal reports, just as I'm telling you here right now, but we lots of times find that 4% articaine, or for those who prefer the 4% prilocaine, the sit nest, those tend to work better on those difficult to anesthetize patients. And then I do use a little bit of the long-acting bupivacaine, Marcaine or Vivicaine, to control pain for post-operative procedures when I know the patient's going to have a good bit of post-operative pain. So that's my basic armamentarium of anesthetic agents. So let's shift into looking at blocks, and as you can see, there's quite a few different blocks. I am going to focus really on the inferior alveolar nerve block, our conventional IA block technique, and on the complete mandibular division nerve blocks, the Gau-Gates and the Vazirani-Akinosi mandibular division block techniques. So first off, our conventional bisection technique for the inferior alveolar nerve block, what we normally do is we put a finger on the anterior border of the ramus of the mandible, feeling the external oblique ridge, and then we feel inside to find the internal oblique ridge. With that fingertip there, we then have another finger out around behind the jaw outside, and we are going to bisect the jaw between those two fingertips, go in and contact the bone. And as you can see on the diagram on the right, this should put us in a position above the mandibular foramen. This is certainly what we're seeking so that we anesthetize the nerve before it dives into the bone and is protected from our anesthesia. Now, these landmarks are very good landmarks. Using the depth of the coronoid notch, feeling for the internal oblique ridge, finger around behind the posterior border. As you can see from this very old anatomical study, those landmarks will put us above the mandibular foramen a good 97–98% of the time. So we have a very good chance of success with those particular landmarks. But when we look at this technique overall, what we're talking about here are the anatomic norms of the bone structure, of the width of the mandible, the height, and so forth, how much muscle mass is attached to the bone, are the nerve pathways normal nerve pathways, or are there accessory branchings going on, or are there anomalous nerve pathways, all these sorts of things. And we're also assuming that there's a normal, healthy local tissue environment there. There's no inflammation or infection that would alter the dissociation of our anesthetic solution. So we see the success rate of our conventional technique. For most of us, it's in the upper 80s to lower 90%. You can see here, this is the full range when you look at all the various studies that are out there. But I'd say on average, most of it's around 90% plus or minus a little bit there. Okay, but one problem I have with the conventional technique is that I know there is a lot of variation of the mandible. I was also trained as an anatomist, and I teach anatomy in dental school. I've done thousands of dissections, and I've seen tremendous variation in the shape of the jaw and in the pathway of the inferior alveolar nerve. So I know that this variation occurs, and certainly when we look at people and see a class 3 prognathic occlusion, lots of times that can throw us off on correctly identifying the proper landmarks. When people start losing teeth, get resorption of the alveolar ridge, that can throw us off. And it's worth noting that children are not the same anatomy as adults. It's not just smaller anatomy, they are actually different physical anatomy because the ramus has not grown to the same dimensions that the adult mandibular ramus has. So there is quite a bit of variation in the anatomy. Another thing that has always concerned me about the conventional inferior alveolar nerve block technique is that we're taught to come in and contact the bone gently in the area where the nerve is approaching the mandibular foramen, which seems to me puts that nerve and the blood vessels, the inferior alveolar artery and vein, at some risk of potential injury because we could pin them up against the bone in that location. And here on the right side dissection picture here, you can see this is the inferior alveolar nerve coming down here to the mandibular foramen, and right behind the needle here, this is the inferior alveolar artery, and just underneath that is the inferior alveolar vein. So we've got some pretty good sized structures there that we could get potential involvement in, that we really don't want that kind of involvement. Okay, final thing is that the conventional inferior alveolar nerve block is a mandibular block, yes, but it is not a complete mandibular division nerve block. We need to give a lingual block to get the tongue and lingual soft tissue. We need to give a separate long buccal block to get that little bit of cheek area there. Now with the normal technique, we back out halfway and we get the lingual nerve, so that's not a big problem there. But we do need to give a second injection, a separate injection, to get the long buccal area. And it's important to understand that that long buccal nerve is a very common accessory innervation pathway to the mandibular molar teeth. So not only do I want to get that long buccal nerve in order to have the complement of complete soft tissue anesthesia for patient comfort, but I also want it for insurance that I'm going to have true pulpal anesthesia of those mandibular molar teeth. Now this brings up an issue about how much anesthetic should I be dropping in these various injection sites. Well, for infiltrations, using 2% lidocaine with 1 to 100,000 epinephrine, we generally say a half to 3/4 of a cartridge is a pretty good ideal volume to use for the infiltration. Now, as I mentioned, I use articaine for my infiltrations. I reduce the volume of anesthetic that I'm delivering with articaine. I drop it down to about 1/3 to 1/2 of a cartridge of articaine for my infiltrations. Now, when we look at blocks, and here we'll look at a conventional inferior alveolar nerve block technique, as you can see, ideal volume would be 3/4 to a full cartridge of anesthesia to completely bathe that nerve and get good quality anesthesia. But I want you to think about our conventional technique. When we go in, we gently contact the bone at the bisection point, we back off slightly, aspirate, and then we drop, about 1/2, 2/3, 3/4 of a cartridge of anesthetic. And then we back out halfway, stop, aspirate, and drop the remainder of our anesthetic solution to get the lingual nerve. Well, what we've just done, if we've dropped as much as 3/4 of a cartridge of anesthetic for the inferior alveolar nerve, we have dropped a minimal volume to really good, ideal, good quality anesthesia. And so this is important to understand because so many of us, we kick ourselves and go, I'm a bad dentist when I don't get my anesthesia with my first inferior alveolar nerve block. I'm doing it wrong. What's my problem? Well, no, there's not necessarily a problem. The fact is that very frequently we need to give a second inferior alveolar nerve block. And I actually know a good many practitioners who just automatically give 2 cartridges for an IA block regardless. And I have no problem with that technique. I just have to admit I'm a little more conservative, and I prefer to only use 1 cartridge if that's all I really need. So I prefer to test it a little more carefully before I decide whether or not I need a second injection there. Okay, we'll come back to that issue. All right, now I want to compare the conventional inferior alveolar nerve block technique to our true complete mandibular division nerve blocks, the Gao-Gates and the Bosroniak and Osi techniques, which should give us the complete quadrant on any given side there. So the Gao-Gates technique is the highest of these 3 techniques. The target is the neck of the condyle, and as you can see, that's going to be highest along the nerve pathway. The Akinosi is about halfway in between the Gao-Gates up above and our conventional bisection technique down below. So the Gao-Gates technique was originally described as having 2 planes, and this is where things sometimes get a little bit of confusion here. The alpha plane, very simple. It's from the intertragic notch of the ear to the corner of the mouth and across to the opposite corner of the mouth. And what this does is it gives us our anterior-posterior orientation. This would be for the syringe. And here on this left-hand diagram, here's the syringe. This is a line drawn on the patient. This is not the needle here that we're looking at. This is illustrating the alpha plane, the orientation of the syringe from anterior to posterior. Now, our target here is going to be to contact the bone at the neck of the condyle, and obviously this is with the patient's mouth wide open. Now, we could give this as an extraoral injection. I don't recommend that, but we could palpate where the condyle is in the neck in the fossa of the mandible, and then feel the articular eminence, and just in front of that, along the inferior border of the zygomatic arch, where we feel that depression, we could put our needle in just below that site, and we would be coming in and approximating where the inferior alveolar nerve and all of its other portions of the mandibular division of the trigeminal are coming through the foramen ovale. But let's be realistic. We're going to give this as an intraoral injection. So when we have the patient open wide, this condyle translates forward out over the articular eminence. So if our target is the neck of the condyle, that means our target is now immediately lateral to the foramen ovale, immediately lateral to the complete mandibular division of the trigeminal nerve. So we want to have the mouth wide open because that will bring our target right out there next to the foramen. And here on the left side, we're looking at the base of the skull. Here we see the mandibular foramen. Here's the articular eminence. And right here, this is the foramen ovale. So again, with that condyle translated forward out over the articular eminence, our target is just lateral to the foramen ovale with the mouth wide open. All right, so the first thing in the technique is we want to establish the alpha plane. Now, I've always felt a little odd putting my fingers into people's ear canals and telling them I was going to give them an intraoral injection. So I've modified the technique, and we've been teaching this here at University of Pacific for quite some time. What I do is I put my fingers in front of the patient's ear and just below the zygomatic arch, and I ask them to open and close their jaw a couple times. You can do this on yourself. And when the patient opens and closes, you can feel that bump of the condyle sliding backwards and forwards. So once I've identified that bump, I have the patient open wide, and then I slide my finger down right below that bump and then hook my finger back behind the neck of the condyle. So my finger is now resting behind the neck of the condyle. Okay, now let's go to the intraoral aspect here. Our penetration site is going to be in the maxillary vestibule, and it's in the vicinity of the second molar tooth, or sometimes a little bit behind that. It's going to depend a little bit on the angulation there. And this is where most people have the greatest difficulty with this technique. It's what angle should I be at in giving this injection? So looking at some of the original Gowgate's work, he described this angulation, medial lateral angulation, as the beta plane. And here's a diagram from one of his early papers. And he talked about our angulation should be parallel to the angle at which the tragus deviates away from the side of the face. Yeah, I have to admit, I look at diagrams like this and I just start rolling my eyes. To me, I find that rather confusing. So let's take a look at these diagrams here. These two jaws are virtually identical in the anterior, but notice that this right-hand jaw flares out much more to the lateral as we go posteriorly. The left-hand jaw is pretty straight going back. The right-hand one has a very distinct flare to it. So people ask me with this technique, which contralateral tooth are you going in over? And all I can say is, it depends on the shape of the jaw. With this narrow jaw, I'm coming in over the cuspid tooth. With this wide flaring jaw, I'm coming in over the second bicuspid tooth. So part of what I'm doing, when I've got my finger behind the neck of the condyle, my other finger is inside the jaw, same landmarks that we use for the conventional inferior alveolar nerve block technique. My finger is in the depth of the coordinate notch and feeling the internal oblique ridge to retract the tissue there. And what I'm doing with those two fingers is I'm feeling how much flare is there to this jaw. Okay, so that's number one. Now, the next thing here is to think about when I'm lining this up to give the injection. First thing I do before I come in with a syringe is I take a Q-tip, a swab with topical anesthetic, and I put it on my penetration site up in the maxillary vestibule. Now, with that, I'm trying to line up where I think that's pointed towards my finger. I get that all lined up, and then holding that in place, I pop my head up a little bit. So I'm looking down on my patient like this is illustrated in the photograph here, and I look to see, is that Q-tip pointed right towards my finger? If it's not, I will correct the angulation a little bit, and then I go back, look in the mouth, and I see how close am I to the upper teeth, how close to the lower teeth, which contralateral tooth am I over, what are my landmarks here? So I get all that positioned, and then when I take the swab out, I come back with my syringe, I put the tip of the needle into the tissue and stop. Again, I line things up, I pop my head up like this, I call it the woodchuck thing, popping out of the hole, and I look to see, am I aimed towards that finger? This syringe doesn't look like it's aimed quite right towards my finger. I'm going to push this over to the contralateral side a little bit more. And then I'll go ahead and insert until I contact the neck of the condyle, until I feel that bony contact. Okay? Now, the mouth must be wide open. That's number one. My penetration site in the maxillary vestibule, around or a little bit behind the maxillary second molar, and I'm aiming towards that finger that I've got positioned behind the neck of the condyle. Okay, depth of penetration about 25 to 28 millimeters. I should contact bone. I'm using a 27 gauge long needle. The length of that's about 32 millimeters, so I'm not quite burying that up to the hub, and I drop a full cartridge of anesthetic. Now, what's also important is to note this down here. We want to keep the mouth open for a minute to a minute and a half after we deliver that injection. The reason being that is that if we let the patient close down immediately, that will sweep that bolus of anesthesia posteriorly away from our foramen ovale. We may still get anesthesia, but our onset's going to be slower, and we may not get as profound an anesthesia. So we ideally want to keep the jaw open. Now, I know you're thinking, that's a long time to keep the jaw open, and you're right. So what we do is I put a bite block in on the opposite side of the jaw here, and allow the patient just to relax against that, and I can keep them open just as long as I need to deliver this injection and keep them open afterwards for the minute to a minute and a half that's required. Okay, now the Vazirani-Akinosi technique, this is a closed mouth technique, a very, very unique technique. Again, it's about halfway in between our target site for the Gowgates and where our conventional IA is delivered, just a little above the mandibular foramen. What we're trying to do with the Anesthesia Vazirani, these are two gentlemen that published almost identical papers 17 years apart, so that's why we have both names on the technique. What we're trying to do is to sneak our needle in between the ramus of the mandible and the maxillary tuberosity with the jaw closed. All right. Now, what we're going to use is the mucogingival junction of the maxilla. That's going to be our guide plane. We're going to go parallel with that, parallel with the occlusal plane of the teeth, back between the condyle, trying to keep the needle as close to the ramus of the mandible as we can. We want to keep our anesthetic close to that ramus. Now, our depth of penetration, again, is about 25, 28 millimeters or so. It's important to note there is no bone contact with this technique, so it's extremely important that we have good visibility back in the cheek. So what I do in this technique is I have the patient open first. I slip my finger up into the maxillary vestibule, well up into the top of the vestibule, and then I let the patient close down. But as they're closing down, I ask them to cock their jaw, slide their jaw out towards the side that I'm injecting. This allows me to really get good control of the upper lip and the whole vestibular area, to really retract well so that I can see where I'm putting that needle, and I can see as I'm putting it in, I can follow the depth and penetration, so I'll stop a little bit shy of completely burying that needle up to the hub. Okay. Now there's some variations. We could do this technique with the jaw open a little bit, or we could do a little bit of a bend in the needle to keep it closer to the medial side. So there's a number of things you can do to make this work a little better for you. One thing I want you to note is the diagram on the left here. In that our quadrant anesthesia, you'll notice it's a little different out here in the long buccal area, and that's because this technique is not as reliable for getting the long buccal nerve as is the Gao-Gates technique. Okay, so let's back up a little bit and let's compare these three techniques for complete quadrant block, if you will. All right, so success rates. Conventional technique, again, most of us with experience were around 90% plus or minus. Gao-Gates, 90 to 100%. Well, okay, in a study you might get 100%, but in real life, day-to-day dentistry, we are never going to have 100% success. So let's not worry about that. But we can see that with experience, it's a good high success rate. Now, I'll tell you, I was not taught this technique in dental school. I learned the Gao-Gates technique afterwards, and I started using this technique as a backup. When my first inferior alveolar nerve block didn't work, I started using a Gao-Gates technique to give my second injection. And it seemed to work. Now, did it work simply because I gave more volume, or did it work because it's a better technique? I really didn't know. But by using that as my backup, I got comfortable with the technique, and I got to where I was very consistently touching the neck of the condyle with the tip of my needle on each injection. So I felt very good with this technique. And then I finally took that major leap of faith and said, look, this technique seems to be working. Let's try it for my first injection. And what I found when I started using the Gao-Gates for my first injection, I had a higher success rate with getting anesthesia with my first injection. So that was how I transitioned to this Gao-Gates technique. All right, now the Vazirani-Akinosi technique, as you can see, there's a broad range of success rates here from the studies that are published. But I'd say most people are in a fairly good upper area. The 80s to 90s is more common success rate there. But one thing when you read these various studies, you have to ask the question, how are they defining success? That's extremely important. So for example, here in this illustration, this is a 3 cc syringe here. Now, certainly we would all expect that if we're using a larger volume of anesthesia, we are going to have a higher likelihood of success. So when you read these various papers, you have to look carefully at exactly what the technique is that they're using, what kind of syringe, what kind of volume they're dropping for anesthesia. Because certainly 3 cc's is a whole lot different than the 1.8 we have in our conventional 1.8 cc cartridges in the United States. All right. Now, looking at this diagram here, you'll see I have a triangle drawn out here. what we're looking at is the base of the skull. On the left-hand side would be the midline of the head. This is the tongue down here. Here we have the ramus of the mandible. This is the zygomatic arch. So we see here the medial pterygoid muscle, the masseter muscle, the temporalis muscle, and within the triangle, cut and cross-section, is the lateral pterygoid muscle. Now this triangle, if we think about this in 3 dimensions, it's an upside-down pyramid. The apex of the pyramid is roughly at the mandibular foramen, where the inferior alveolar nerve enters into the bone. The base of this pyramid is up at the base of the skull. So when we do a conventional inferior alveolar nerve block, we are dropping our anesthetic at the apex of this upside-down pyramid. Volumetrically, a relatively small area, histologically, relatively dense tissue, and not very much fatty tissue there. This is important because our anesthetics are lipid soluble. They like lipid, they diffuse through lipid very readily. So what this means, because of the denser tissue down here, is that wherever we drop our anesthesia with a conventional technique, if we're close to the nerve, we will undoubtedly get good anesthesia. But if we're not close to the nerve, the odds are fairly good we won't get good quality anesthesia. And that's because of the histology of this localized area. Now, when we think about the Gauge up here near the base of the skull, obviously volumetrically this is a much bigger area, which may be bad for us because we may need more volume of anesthetic up here. But histologically, the good thing here is that it's looser connective tissue and a lot more fatty tissue, which means our anesthetic will diffuse over a broader area. So it will almost undoubtedly get to the nerve. The question is, are we going to have adequate volume? So with all these techniques, I always say we are going to use 1 to 2 cartridges of anesthetic. We are going to give 1 to 2 injections to get successful anesthesia. Okay, now, the other thing about success is, what are we talking about? Are we talking about truly getting the teeth we need to work on, or are we talking about just the patient has signs of some anesthesia? You know, certainly when I look at a diagram like this and thinking about the Gauge technique, being closest to the foramen ovale, it has the best likelihood of anesthetizing all the nerve branches that could possibly be going to the teeth. And here's something that you really need to understand, is that all of these nerves, the long buccal nerve, there's excellent anatomical studies that show branches come off the long buccal nerve, dive into the bone, and either join up with the inferior alveolar nerve or they go directly to mandibular teeth. Same thing with the lingual nerve, same thing with the mylohyoid nerve. All these nerves give off branches in various places. And, you know, in my opinion, when I look at this, if I'm getting the nerve closest to the foramen ovale, I don't have to worry as much about whatever branching is occurring. So certainly that's a big contribution to the high success rate of the Gauge technique. Now also, thinking about that being the likely most successful, the fewer injections I have to give my patients, the happier my patients are. So if I can get all the nerves and branches that I might need to get good anesthesia, that's going to be more comfortable for the patients as well. Now, looking at onset of anesthesia for these techniques, you'll notice that at 5 minutes, the Gauge technique is not looking real good. At 10 minutes, it's looking equal to all the others. The reason for this is that at the foramen ovale, we're talking about a very big nerve bundle. And if you understand the central core theory of anesthesia, it's going to take more time for that anesthesia to penetrate all the way into the very center of that nerve bundle. So what the central core theory says is that the fibers around the outside of the nerve bundle are going to the more posterior teeth, the molar teeth. The fibers at the center of that bundle are going to the most anterior teeth. Okay, so when I give anesthesia, I ask the same question that all of us ask, and I ask the patient, is your tongue starting to feel numb? Is your lip starting to feel numb? And at about the 5-7 minute mark, I will ask that question after giving any of these techniques. And if the patient says yes, that's good. I'll wait a little bit longer to see whether or not if that anesthesia is getting to be more profound, if the patient reports they're feeling number. If the patient reports at that 5 to 7 minute mark that they're not feeling any numbness there, I give a second injection right at that point. But that only tells me whether or not I have soft tissue anesthesia. It doesn't tell me about pulpal anesthesia. So to check pulpal anesthesia, what I do is I'll take a Q-tip and spray a little bit of endo-ice on there and then put that against the tooth. If the patient reports no cold sensitivity, I'm 99% assured that I have pulpal anesthesia of that tooth. If the patient says they're feeling that cold, I then give a second Gao-Gates or IA block, whichever technique is I'm using at that point. Okay? So that's how I gauge my anesthesia and how I work with the onset time frame, which varies widely from one patient to another. Different people react differently to these chemicals that we're using. All right, the risk of positive aspiration. The study that had the highest success rate for the conventional IA block technique also had the highest positive aspiration rate. I want to be successful, but I'm not a vampire. I don't want to be sucking blood all the time. Gao-Gates had the lowest positive aspiration, 0 to 2%. The Vazirani-Akinosi also very low at about 2%. And you'll notice on the diagram here, there's no major vasculature up here in the area where we would be targeting for the Gao-Gates at the neck of the condyle. Down here with a conventional technique, we've got the maxillary artery, the inferior alveolar artery, and so forth. So there's a lot more vascularity as we go down lower. Now, other undesirable side effects, hitting the nerve, we've all done that. The patient gets the electric shock thing. Going into a muscle, potentially causing muscle trismus, accidentally injecting the parotid gland. We get temporary facial paralysis, and it's always been temporary with an anesthetic injection. But we don't get dental anesthesia, which is highly embarrassing. This is most common with our conventional inferior alveolar nerve block technique. Now, with the Vazirani-Akinosi technique, sometimes what we see is we're giving a mandibular block, and we don't get mandibular anesthesia, we get maxillary anesthesia. Oops. Hopefully there's some work to do on the maxilla that we can justify having gotten that anesthesia there. Other unusual things that occur. Sometimes we have seen loss of eye movement with these injections. There's even been reported temporary blindness. These are very, very unusual. But these kind of things are more common with the Vazirani-Akinosi because there's no true bone contact. All right, so let's summarize these techniques here. Certainly the conventional technique first described by William Halstead back in the 1880s. Most familiar technique, good, simple landmarks. This is what we're all taught in dental school, fundamental technique. Good success rate, up there around 90% for most of us. Disadvantages is that there is a increased incidence of positive aspiration with higher success rates, moderate incidence of trismus and or nerve injury, nerve paresthesia. But to me, the biggest thing is we have to use multiple injections to get all the possible nerves that might be going to the tooth we're trying to work on. Now, for the Gao-Gates, high success rate with experience with this technique. It takes practice. Extremely low incidence of positive aspiration. Significantly reduced incidence of trismus or nerve paresthesia. So a safer technique, and this is borne out through quite a number of papers. But the best advantage to me is a single injection to get all the nerves that might be going to the teeth that I want to work on. That to me is the most important. Disadvantages, yes, it's a difficult technique. Yes, it takes some time and some patience, both your patients and patients in your chair, to master this technique. A little slower onset of anesthesia, but that's not a big problem, I don't think. All right, our Vazirani-Akinosi technique. Again, a pretty good high success rate, better than the conventional, not as good as the Gao-Gates. Almost as low as a positive aspiration rate as the Gao-Gates. Pretty significantly reduced incidence of trismus and paresthesia like the Gao-Gates. Again, potentially single injection to get all the nerves. A couple of other advantages. For phobic patients, this is less threatening because their mouth is closed when you're giving the injection. And this injection can be used for patients with severe trismus who can't open. We can go in and deliberately deliver a lot of anesthesia to anesthetize the motor innervation. We can then work the jaws, break the cycle of muscle spasming, and get this patient back to normal function sooner. Disadvantages, greater potential error in giving this injection because there is no bone contact. We don't know exactly where the tip of that needle is, and that's also why we see the more unexpected or unusual side effects. And I think also the fact that it's the least reliable for getting the long buccal nerve, which we know is a very important accessory innervation to mandibular molar teeth. So the logical question is, what technique is best? Well, this depends on a number of factors here. And I like this Gary Larson cartoon here. It depends, number one, are you doing the technique completely correctly? These cavemen have a great saber-toothed tiger trap. They are going to trap the tiger. But they're going to find they've got a problem because they've got one detail of the technique a little bit wrong. And so we have to be very careful about our technique in doing these injections. Now, one more thing I find very helpful with assessing problems with mandibular anesthesia. I like getting panoramic radiographs as part of my baseline with new patients. But here's a patient. This was a patient I had in private practice. This was a very large guy. He was an ex-pro lineman in pro football. Look at the size of the inferior alveolar nerve canal on both sides of his jaw. This tells me that it's going to take a little more time for onset of anesthesia, and again, because he's so big, I might need to drop a little more volume of anesthesia to speed up that time frame a little bit. All right, so that's nice to know, but it's not revolutionary. Here's a patient with a fractured jaw, and they've had surgery to have plating done back here. Now, let's say I wanted to do some bone grafting here as a predecessor for putting in implants. Would I want to give a conventional inferior alveolar block back here? My answer is no. With all the scar tissue and abnormal anatomy back here, no. This is where a Gauge-Gates would definitely be the more ideal injection for this person. But let's say this person had a subcondylar fracture and they'd had surgery and plating done up here. In that case, I wouldn't want to do a Gauge-Gates because of the abnormal anatomy up there. Or if you have a patient, and I always describe this classically as being little old ladies that just can't open their jaw very wide, I can't do a good Gauge-Gates injection on those folks. So I can't use that technique on everybody, which means we need to know multiple techniques. Now, another thing with this picture is that we could use a mental block to get the anterior teeth. We can see the two mental foramina here on this picture, but we know that it's 97–98% of the time in close proximity to the apex of the second bicuspid. So what I do for mental blocks is I come in, it's essentially an infiltration. I use articaine, half cartridge. I drop my anesthetic off the apex of the second bicuspid, take the needle out, and then I massage the anesthetic into the foramen. And what that does is it gives me buccal soft tissue, pulpal anesthesia, and then it also gets me lingual anesthesia as well. So I like using articaine for that mental block because it makes it so much easier. And I can use the mental block bilaterally to get all the anterior teeth from second bicuspid to second bicuspid to do restorative work, and that's really handy. That's really nice. I don't like giving complete mandibular blocks bilaterally because that's very, very uncomfortable for patients. Okay, now here's another panoramic film. This was a gentleman that came in. He was in his 50s, fully edentulous, obviously. His history was that he had all of his teeth taken out at age 28 because he was so frustrated with dentistry they could never get him completely anesthetized, particularly on the mandible, that he had all of his teeth taken out. And he said yes, he was not completely anesthetized when he had the teeth taken out. So you look at this panoramic film, and here's his inferior alveolar nerve canal. Now, if you look carefully, you'll see right here, there's a second inferior alveolar canal. Actually, he has bilateral, bifid inferior alveolar nerves. Now, this is not real common. Here's an older study, but 4 patients out of 5,000. Look at this picture. 1, 2, 3 canals that we see for the IA. So what this tells me is there's a lot of branching that occurs in these nerves, and we may not necessarily see it reflected in the bone. Remember, these nerves travel through soft tissue for a good ways before they even enter into the bone. So again, there's a lot of variability of these nerve pathways. So again, I think the Gauge-Gates has the highest likelihood of success. All right, last thing here, let's talk about hot teeth. These are the most challenging teeth to get anesthetized. So we're taught to give a block injection away from the site of localized infection. This is so that the anesthetic agent will properly dissociate into the tissue and we'll get a better anesthetic effect. And then also we don't want to inject into the localized site because we'll cause pain and we might actually make that infection worse. All right, well, this is a very interesting paper published in 2010 out of OOO, and this was a study done on teeth with irreversible pulpitis. So look at this here. In these cases, giving a block injection, the Gao gates was only successful half of the time. Conventional IA block, only about a third of the time. Using buccal and lingual infiltrations with articaine, successful about a quarter of the time. But the key statement here, I think, is that none of these techniques was completely successful for anesthesia of these hot teeth by itself. Almost always, well, a significant percent of the time, having to do a secondary injection. So, it used to be for a secondary injection, we'd give a periodontal ligament injection, or the endodontist did a lot of intraosseous injections. But if you read the endodontic literature now, what you'll see is numerous papers citing that they're using a buccal and or lingual infiltration with articaine as a secondary injection in addition to the block. So they'll give the block with lidocaine, whether it's a Gao gates or an inferior alveolar block, doesn't matter, and then they'll give a buccal and or a lingual infiltration, half cartridge each, of articaine next to the tooth they're trying to work on. And they get very good success with anesthesia that way. So again, this brings us back to the slide I started with of using that buccal and lingual with articaine for a higher success rate. And if that works on hot teeth, then this is certainly going to work on normal healthy teeth. Okay, so let's wrap up this talk here and we'll get to the questions. So reasons for anesthetic failure. I think an important message here is that there's a lot of anatomical and physiological variation in human beings, and because of those variations, it throws our techniques off. Local anesthesia is just like dentures. Dentures are not one size fits all. Neither is local anesthesia. In order to have success, we need adequate anesthesia to ensure patient comfort for the duration of the procedure. So that's going to depend on the nature of the procedure, how invasive it is, how long it's going to take. It's going to depend on the patient. How fearful are they? How do they react to local anesthetics? Everybody's a little different. So we need to know multiple techniques, and I really feel it's important to know all of these techniques for mandibular anesthesia. We need to have backups. This hammer is very tempting. It will work as a backup, but it's not a real good practice builder. So we want to think about our techniques. Infiltrations can work in some situations for single teeth. Blocks for multiple teeth. Which technique is best depends on the specific needs, specific problem that we're dealing with, and it depends on our using the technique properly, doing it properly. So finally, in order to have good, successful dentistry, we need to have patients that can open wide like this person. If I could get everybody to open up like an alligator, I would have no problem doing dental treatment. But you have to gain patient trust in order to get patients to open wide. And a lot of that trust is being able to give good, comfortable, very successful, profound local anesthetic injections. We need to be able to earn that smiley tooth on the bib there.